So massive welcome to everyone who is joining us today. Great to see you all. So we're just about to start our next webinar in our NIHR Birmingham Biomedical Research Centre's webinar series, which we're really pleased to welcome you to this evening. We're going to be hearing from Professor Palak Trivedi, who's going to be talking about the gut microbiome's secret role in autoimmunity. So who's really in charge? Hopefully we'll find out a little bit more from you in a minute. So welcome, thank you. And I'm just we've got a lot of people who've registered today, so I can see a lot of registrations happening right now, people attending. Welcome, everybody. Great to see so many people have wanted to sign up to this today and join us on this not very warm evening, actually, over in Birmingham. But at least hopefully you're warm and dry. And we are delighted that so many people have taken the time today to join live. So you get the golden opportunity of actually being able to ask our expert some of the questions that you might have as a result of listening to the talk, or perhaps you knew before that you wanted to talk to him. So welcome. Right, I think we've got a really good number. We've got well over 120 people have joined so far. So good evening. We're absolutely delighted, as I say, to see you all today, and we're going to be talking with you. But I'm just going to share my screen now so that you can see some of the slides we've got. And hopefully you can see that my screen is being shared. So terrific. Okay. So before we actually go ahead, though, I just want to give you a little bit of a quick introduction on to who we are and what we do at the NIHR, so the National Institute for Health and Care Research, Birmingham Biomedical Research Centre, which some of you may know as the BRC. So first of all, we're a collaboration, like all BRCs, so all biomedical research centres funded by the National Institute for Health and Care Research are a collaboration between the university and the NHS. So in our case, we're managed by the University Hospitals Birmingham NHS Trust in partnership with the University of Birmingham, and along with our partners that you can see here on the screen. So there are a number of different partners, so we're not just Birmingham, but we are publicly funded because the National Institute of Health and Care Research is the research arm, if you like, of the NHS. And there are 20 biomedical research centres like ours across England, all working to improve people's health. So what do we do? At our research centre, we've got doctors and nurses and other healthcare staff working together with researchers to take new scientific discoveries that we find it in science labs and turn them into diagnostics, such as tests, perhaps, or procedures which help to identify illness and injury and treatments. And our research in Birmingham specifically focuses on the cause or the causes and effects and treatments of inflammation or things affected by inflammation. Now, inflammation is a normal part of the healing process, and we've probably all experienced that at some point. You know, it might be swelling or pain or something, or loss of function a little bit, perhaps, or movement. But sometimes the body does overreact, and too much inflammation causes further problems, and it can be linked with many health conditions that you may have heard of, arthritis, infectious diseases, diabetes, cancer, and gut diseases. And, you know, these are the things that we're going to focus on today in the talk. So, but we want to hear from you as well. So we've actually got a opportunity for you to use the Q&A function. So you may see that on a bar, maybe at the bottom or top of your screen, depending on what kind of device you're using to observe this. So you can ask questions at any point during the talk, but you have to type them in. So just click on that Q&A icon and then you can do that. And then we've got a chance at the end of the talk so that you can do that. And we will also be recording this, as you know. So again, you can always watch it back or share it with other people. And we'll share the video when it has been uploaded as well. We'll let you have that link because we've got your email address from you registering to attend today. So thank you all very much for attending and using that Q&A function. And what I'm going to do is stop talking now to pass you over to the expert who's going to be talking this evening, Professor Trivedi. So thank you very much. Over to you, and we look forward to hearing from you.
Well, thank you very much to Laura, as well as the organisers of today's webinar. It's very humbling to talk on this particular topic. So full disclosure, I am not a microbiologist. And second disclosure, I am not an immunologist either. I am a gut and liver doctor, and my main area of research and clinical interest is how can we understand the role of the gut, its microbiome, and its immune system in driving other more systemic diseases. And so in the next 20-30 minutes or so, I'm going to present a bit of background concept and some data before moving on to how we can target this therapeutically for patient benefit. So I can move my slide forward. Just one second. See, it's just moving. Ooh, I've lost control of the slides. All right, here we go. Okay, let's try and do that. So this concept of hora autoticus was first proposed by a Nobel Prize winning physicist called Paul Ehrlich. And Paul is actually the father of modern immunology. He developed what we call the side chain theory of the immune system, discovering the concept of antibodies. He first of all developed the anti-diphtheria serum that we now sort of predated vaccination. Also developed the first cure for syphilis. Now, Paul Ehrlich was somebody who thought a lot about the immune system, despite being a physicist, and said that it is impossible for the body's immune system to attack one's own self, impossible for one to develop an autoimmune disease. But then one of his sort of trainees, who then became an eminent physician in their own right, Ernest Wojcicki, he then discovered that actually it is possible for your body's immune system, your antibodies that you use to fight infection, it's cold and flu season, using it to fight those type of seasonal illnesses, they can be turned inward. They can, with the right prompt, turn into cause autoimmune diseases for an organ, a particular organ, like the liver, for example, or the bowel, but also more systemically can cause autoimmune diseases at a broader scale. But there were certain criteria that needed to be fulfilled for something to be quantified as an autoimmune disease. We needed to have direct demonstration of antibodies towards particular tissue-specific targets. We needed to recognize what those antigens were, what those targets were in the body for something to be classified as an autoimmune disease. And we should be able to reproduce that, even say in the lab or in an animal model, for example, and recreate autoimmunity when we take those antibodies and those immune cells from somebody who has an autoimmune disease to somebody else. Now, when I was teaching sort of this concept to my children, and the reason I was teaching that is because autoimmune diseases are common, and as I was saying to Laura earlier on, it was my older son was diagnosed with an autoimmune disease a few weeks ago, and it took about 4 or 5 months to get there. So these are not always diagnosed very quickly. And when we were talking about this and thinking about autoimmune disease, then my younger lad started asking questions. And rather than knowing about the science behind it and the history of medicine, he then found this particular cartoon. And this particular cartoon perhaps demonstrates it better than I can ever do. wherein your own self starts to recognize other parts of yourself as being foreign. And no matter how much your body tries to tell your immune system, I'm one of you, your immune system starts to attack it. And this is a famous cartoon by Beatrice the biologist, who tries to explain things in a way that children with certain conditions can understand, but also conveys things in a nice pictorial way. Just want to move my slide forward again. Just 1 second. Right. So how common are autoimmune diseases? So this is a recently published study from the United States, and what it shows is that out of all women, approximately 1 in 4 will develop an autoimmune disease. So 6% of sort of all women and 3% of all men, but that's the new development rate. But over time, we actually see at a prevalence rate, i.e., the frequency in the general population, it actually is quite common. And what are these autoimmune diseases? These can be things such as rheumatoid arthritis. These can be things such as type 1 diabetes, so childhood onset or very early onset diabetes, not the one that you have in later life, which is often associated with putting on weight and sort of a less healthy diet, but also things like celiac disease or thyroid problems. These can be, these are all autoimmune conditions. I'm just trying to click forward again. There we go, 1 minute. The technology starts to fail us a little bit. Right. So when we look at autoimmune diseases, the other thing that we tend to see is that individuals who have one autoimmune disease often go on to develop another. And more than 1/4 of individuals who have an autoimmune disease go on to develop something else. And there are a small proportion of individuals who have multiple autoimmune diseases. So this then raises the question, are autoimmune diseases genetic? Is it something in the genes that leads to an autoimmune disease developing, which then goes on to having another autoimmune disease in the body? And we do start to see clusters of different autoimmune diseases. It is quite common that we see somebody with, for example, celiac disease, which is a disorder of gluten sensitivity, going on to develop thyroid problems. Somebody who has rheumatoid arthritis can then go on to develop problems, for example, with their bowel or with their liver. So autoimmune diseases do tend to cluster together. Historically, it was thought that autoimmune diseases are quite rare, and indeed some of them actually are. But what we are seeing year on year is that the incidence, so that's the number of new people who are diagnosed with autoimmune diseases, seems to be rising for quite a large proportion of them. Not all, but quite a large proportion. In this particular example, we can see Addison's disease, which is a disorder of your adrenal glands, where the immune system starts to cause poor adrenal gland function. Ankylosing spondylitis, which is a rheumatoid condition that affects the joints, particularly the shoulders, the neck, the spine, and the hips and pelvis. Celiac disease, which I've talked about, Graves' disease, a thyroid problem, rheumatoid arthritis, Sjögren's syndrome, where people get very dry eyes and dry mouth, type 1 diabetes, vasculitis, an autoimmune condition of the blood vessels. These are all going up and up and up. Now, if our genes haven't changed significantly over years and years, why are we seeing an increased rise and increased incidence in autoimmune diseases year on year? What is the trigger factor? If our genes haven't changed, it must be something in the environment that's causing this to happen. The other thing to highlight about autoimmune diseases are, despite some of them being quite rare, they have a big impact on healthcare service provision. I mentioned that I'm a liver physician, so I look after people all the way up to liver transplantation and immediately thereafter for the rest of that individual's life. And what we can see here is that despite things such as alcohol-related liver disease, which is abbreviated here as ALD, being one of the biggest causes of a liver disease in the UK, autoimmune liver diseases are actually very similar in terms of the proportion that we transplant. So actually, when we look at our liver transplant practice, and we bear in mind that liver donors are a very scarce resource, we're transplanting just as many people or even more with autoimmune liver diseases, despite them being so much more rare compared to people with alcohol-related liver disease. Oh, I don't know why it's gone backwards. Just trying to move. So bear with me 1 minute because the slides are a bit slow. Okay. The other thing to highlight with autoimmune liver diseases, and this is specific for liver, is that there's not just one type, which again asks the question: why does somebody who's got a certain set of genes lead to can develop one type of liver disease that is treated one way, and another type of liver disease that's treated another? So this is a bit of a busy slide, which I'll walk through. We have a normal liver, just as an example, and a biopsy of that liver shows, a part of it, what we call the portal tract. Now, that portal tract contains several structures. It contains a bile duct, which is where all the bile, which the liver makes, is drained out of. It contains a portal vein, and that is where the blood going into the liver comes from. And it also contains a hepatic artery, which also delivers blood to the liver. So you have a vein and an artery delivering blood to the liver. That is a unique thing about the liver. Most of its blood supply comes from the portal vein, and that portal vein delivers blood from the gut. When we look at our three main types of autoimmune liver diseases, and I don't expect anybody to sort of to read in depth about what these are, but they will be relevant for the next few slides when I'm talking about how these conditions may be driven by what's going on in the bowel and the gut microbiome. So let's first of all talk about this condition, primary biliary cholangitis, or PBC. This is a condition where 3/4 of the affected individuals are women above the age of 45. It's never seen in children. We find that most people have disease-specific autoantibodies that are detected, and all the inflammation that we see involves the bile duct, so drainage of bile. On the other side of the diagram, you see a very similarly named condition called primary sclerosing cholangitis. This again is a condition that affects the tubes that drain bile, the bile ducts. But what we see is rings and rings of scar tissue or fibrosis affecting the bile ducts. Now, unlike PBC, this condition mostly affects men. And this particular condition, as well as affecting the bile ducts within the liver, affects the bile ducts that drain out of the liver. So we've got two autoimmune conditions, both affecting the bile ducts. And despite them both being classified as autoimmune, they behave very, very differently. Now, the relevance of this is that when we look at autoimmune liver diseases, and we try to understand why people get them and how we treat them, we first must understand how these diseases are occurring and why they are occurring if we're ever going to sort of get along that path. Sorry, I'm just struggling with the slide moving forward. Laura, I may say next slide, please, like Chris Whitty did back in the day, if I struggle, because I'm not able to move them forward smoothly. Can you move to the next one from your end? Thank you. So this is a slide that shows what we call prevalence. So unlike incidence, which is the number of new people who are diagnosed year on year, this slide shows prevalence, which shows the number of people living with the condition. Now, you can see on the left-hand side, 3 different colored dot plots. Each dot is a study reporting how many people in their given country is living with that disease. And on the bottom, what we call the x-axis, which says year, you can see over time how that number is going up. So you can see in blue that that is Europe. In the black and white, that is the Asia Pacific region, and in red, that's North America. And across 3 continents, we are seeing the number of people living with this condition going up and up and up. So the next question is, what happens when people move countries? Their genes stay the same. If I was to move to Australia, my genes aren't going to change, but my environmental exposure will. And indeed, there have been studies that show that when people move from the UK, so this is UK women, you can see in the bar charts here, when they move to another country, the actual prevalence rate in people who move to a country actually goes down, and it starts to mirror that seen by the natives. This suggests that whilst there may be some genetic predisposition, there is definitely an environmental factor that is lowering the amount of people living with the condition. Can we go to the next slide? So that's just a bit of an overview about autoimmune diseases, how common they are, and the fact they're going up. Let's talk about the microbiome, and then we'll talk about how the two things are linked to one another. So a common misconception is that as humans, the vast majority of our body parts are in fact human cells. And what we see is that microbiota, so gut organisms, for example, which is where most of the microbiome lives. And when I say talk about gut, I'm not just talking about the bowel, but I'm also talking about the oral cavity, elsewhere in between. We are full of good and bad bacteria, viruses, fungi, archaea, all of these different organisms. In fact, we probably have as many bacterial cells in our body as we have human cells. The story gets more convoluted by the fact that there are actually infinitely more number of microbiome-based genes in our body than there are human genes. So a common question that we get asked in our clinic, is my condition genetic? And I always say, well, there are certainly genetic contributions, but it is very difficult to convey that concept that yes, there probably is, but it's not your genes, it's your gut microbiome's genes that are impacting how you behave, and in terms of disease and in terms of certain traits. And there are some studies now showing that smoking behavior, your appetite, what you like to eat, your behavior or your interactions, the type of activities that you enjoy, the way that you think is all driven, or not driven, but at least associated with certain types of bacteria and other microorganisms inside your bowel. Next slide, please. Now, I alluded to the fact that there are certain social traits that are driven by your gut microorganisms. And what we are starting to understand is that the functions of these are only starting to be explored. We recognize that certain bacteria, certain organisms promote fat storage, and that's why some people, which can eat no matter what they want and never put on weight, and I call them lucky. And then there are other people who can eat sort of very small amounts of bad foods, and they have very difficult challenges trying to lose weight and burn calories. And a lot of that is driven by early exposures in life that have determined the composition of the gut microbiome. And the same thing is true with the immune system. Next slide, please. So, in this particular diagram, this is taken from the Dutch Microbiome Project. And what this diagram is intending to show is the factors that determine on the left what bacteria somebody has, and on the right, the particular pathways that are influenced as a result of that. Now, you can see 4 colors displayed. You can see orange, which determines cohabitation, co-housing. You can see grey, which is the familial predisposition. You can see green, which is the environmental factors, and blue, which is any additional additive genetics, so something that's not necessarily linked to your immediate family, but as some ancestral genetics that may be present. What you can see here is that the bigger the proportion of the bars, the greater the contribution to the microbiome is from that factor. And as I'm sure all of you will appreciate, the gut microbiome is predominantly driven not by your genetics, but by your cohabitation, and particularly by your environment. So that is the main determinant of sort of what contributes to your gut microbiome. Again, it plausibly explaining why certain autoimmune conditions, which we believe are driven by environmental factors, with a contribution from genetics. I'm not saying genetics aren't important, might be going up and up because our environmental triggers are changing faster than our genetics. Next slide, please. So why do people develop autoimmunity, and how does that link with the gut microbiome? So in our body, in our immune system, we have lots and lots of different cell types. And in fact, we discover new cell types every year or every few years or subtypes that contribute to how we react to certain external influences. But for simplicity's sake, if we talk about cells that drive inflammation, and you need inflammation in the body. You know, if you get injured, you need that inflammatory response to sort of as part of wound healing. You need an inflammatory response to clear infections from the body. These effector cells, and some of them are just sort of I just bullet pointed sort of below the green here. They need to be counterbalanced by regulatory cells, so you don't develop an autoimmune reaction. Our body constantly recognizes certain proteins on different organ structures: liver, bowel, thyroid, eyes, joints, heart, even lungs. It recognizes these, and you might initiate an autoimmune attack without us knowing, because our regulatory cells keep them in check. So whilst a match may be lit in a particular area, very quickly there is a fire extinguisher to put that out. In autoimmunity, what we see is that there is an imbalance, and in multiple autoimmune conditions, there are various defects either in the number, function, or both of these regulatory cells. So the pro-inflammatory responses become unchecked, and these pro-inflammatory responses set up a cascade that drives autoimmunity. Next slide, please. Now, why does this happen? So there have been a series of high impact studies from colleagues of ours which have shown that the abundance or the amount of enrichment within the bowel of certain organisms polarizes, i.e. shifts the immune cells towards a certain direction. It's almost like when you, I don't know, this is a very nerdy thing to say, but if any of you Star Wars fans are there, if you watch the earlier films, what you will start to see is that Anakin Skywalker was nudged into a dark direction by Senator Palpatine. It's a very niche reference. Apologies for those of you who haven't seen it and for my nerddom. But what we see is that you need to have a certain nudge of your immune system so the inflammatory responses start to overwhelm and the regulatory responses start to ignore that that's going on. What these studies have shown is that a particular player, which is the big donut-shaped structure at the bottom, Enterococcus, particularly Enterococcus gallinarum, was responsible for driving the polarization, the shifting of immune cells when they're naive towards what we call an IL-17 secretor cell phenotype. That is a type of effector cell that drives autoimmunity or an immune-mediated responses in multiple parts of the body. Now, what they showed in these studies was that the transfer, and this Enterococcus lives in the bowel, right? So transfer of this particular organism, translocation of this gut to various different structures, be that in the liver, be that sort of in the joints or elsewhere, leads to autoimmunity in those particular areas because it shifts the immune cells towards a particular direction. So the next question is, if you've got an overabundance of this particular player in your bowel, of Enterococcus in the bowel, number one, is that associated with the development of autoimmune responses in a distal site? Number two, is the abundance of it, how common it is, associated with how that particular disease behaves, how the disease may progress over the course of time? Next slide, please. So there is a very straightforward way to do that. And as I alluded to at the start, my interest is what happens to the liver, the bile ducts, and how the gut is responsible for driving that. One of the conditions that I talked about was something called PSC, or primary sclerosing cholangitis, where the immune system, for whatever reason, starts to cause inflammation and scarring around the bile ducts. And you've got bile ducts inside and outside the liver. We do see gut inflammation in the vast majority of people with this condition as well. So if we see gut inflammation, it's common sense to think, well, it must be the microorganisms that are leading to that. It must be the gut organisms driving this process. So we've done experimental studies sort of here, and this is a study from our colleagues in Japan, where you can have mice that are what we call germ-free. So we can raise mice without any form of microorganisms inside their bowel. And you can do a fecal microbiome transplantation from a healthy individual without any personal or family history of liver disease or bowel disease. And that's the second row of mice you can see here. When we do that, nothing really happens. And you can see the first two pink boxes, the white bits are where the tracts are, and you want to see very little or no purple around those tracts, okay? But when we take the stool from individuals who live with PSC and inflammatory bowel disease, and we do a fecal transplantation in these mice, you can see there's lots of purple around these tracts. These mice start to develop inflammation and scarring around those bile ducts. Now, this particular model was a very good proof of concept that the gut bacteria, the gut microorganisms, are not just a bystander or a consequence of a disease, but actually causative, because that's what's leading to the disease in these animals. Now, when we start to look at what particular players are responsible for causing this, we can induce the same type of phenotype, the same type of picture in the liver and the biopsies of these patients when we transfer Enterococcus and also another player called Klebsiella. Now, these particular organisms were shown in these particular studies, and there are studies going on in the same lab in Japan, specifically looking with certain viruses called phages to deplete these in animal studies, and later on, hopefully, trials in human to slow down the development and progression of several autoimmune diseases. The problem when you use virus-based or phage-based therapy to specifically target these bacteria, it's very costly. It's almost like 20 or 200 to 200,000 pounds per vial, and you need multiple vials and multiple treatments to get rid of these things. But the principle is that these organisms were able to cause disease in animal models. The second question then is, how does the degree of abundance, how much of these bacteria are present, associate with progression? Now, these figures are what we call Kaplan-Meier survival curves. What we want is 100% survival. So on the y-axis, you can see 100 or 1.00 in the bottom right. We want everybody to stay on that line. That would mean that 100% of people are staying alive without needing a liver transplant. But what we see in all these figures, and you can see on the left-hand side, KP is, sort of Klebsiella, EG is Enterococcus. What we see is that in people who've got high values of these in their colon, they have a very steep drop-off down these stairs. They start to head towards zero, with an increased rate and an increase of needing liver transplantation and sadly passing away from their liver disease. And you can also, in other studies, separate them out. You can see on the top and bottom on the right that the abundance of Klebsiella in pink, the low abundance of Klebsiella in pink is associated with a much better trajectory than in the black steps, where people tend to need transplantation, and very few of them survive without it. And similarly with Enterococci, which is a plural form of Enterococcus, in blue, with low Enterococcus, very few people end up needing a transplant or passing away from their liver disease. But in red, when you've got high levels of this bacteria, the outcomes are very poor. So there is a proof of concept that these organisms not just lead to the development of the condition, but their abundance leads to disease progression. So the question is why? So why are these organisms leading to disease progression in this? Now, what we found in this particular autoimmune liver disease model is that there are certain proteins that are present which call the immune cells to the bowel in people with inflammatory bowel disease, in people with other forms of gut inflammation, that we sometimes find in the liver of people with autoimmune liver disease. And indeed, there are similar parallels in people who've got autoimmune joint conditions. There are certain proteins that are found in other structures that ordinarily are only found in the bowel. So why does that happen? So when you have an immune response in the body, you need your lymph nodes to tell your immune cells where to go. Your lymph nodes are very much like the post office that will say, there is inflammation in your bowel, there is inflammation in your joints, in your skin. This is where you need to go. And it imprints them with a particular stamp / postcode. In the bowel, this particular stamp is called CCR9, and you can see that at the top of where it says gut tropic T cell, the CCR9, and then A4B7. That is the stamp that's put on cells to tell them you need to go to the bowel for an immune, because that's where the problem is. What we see in the bowel is that the postcode, which is where the stamp needs to go, You have other molecules, which I've labeled here, CCL25 and MADCAM1, okay? The names aren't really important. It's just to illustrate the concept. You have a postcode and a stamp that tells it where it needs to go. But what we see in autoimmune liver disease, PSC here, is that in the liver vessels, what we call the sinusoids, we also start to see MADCAM1 and CCL25. And these are molecules that we ordinarily should only be found in the bowel. But the gut bacteria and the inflamed gut lining produce lots and lots of different products, one of which are what we call amine substrates, which is illustrated at the bottom. And these amine substrates can interact with various enzymes. I put an enzyme here called VAP1, which is an enzyme. And when you give a substrate to this enzyme, it releases things that cause the upregulation of molecules in the liver that we normally only find in the bowel. So the gut is producing things that lead to the liver almost looking like an inflamed bowel. So the immune cells from the bowel then travel to the liver itself. So that is one particular way in which the gut microorganisms sort of can cause inflammation. Next slide, please. Maybe because there's quite a few people on the call, so it's a bit slow on my end. Apologies. So how can we move from identifying that there are various different gut organisms to treating those gut organisms for therapeutic benefit? So in Birmingham, thanks to the BRC, first of all. Secondly, thanks to our funders. So LifeArc sort of have funded a lot of this work, as have the NIHR, the Wellcome Trust and the Medical Research Foundation, as well as significant industry partners. And above and beyond sort of all of that, the colleagues that I work with are absolutely fantastic. So our nursing team at the University Hospital of Birmingham are the best people I can work with, and I can't name all of them, but certainly this is not my last slide, by the way, but I want to mention them here because delivery of sort of these trials very much dependent on Diana Hull, Kashmir Badal, Penelope Rogers, Michelle Panton, everyone, Gifty Riverson, all of them are absolutely superb. I'm deliberately name calling them because if you're ever in Birmingham and doing a trial, these people will look after you like family. They're absolutely brilliant. And these particular trials have been delivered in a rare disease population where it's very hard to identify individuals who meet specific eligibility criteria, who are happy to travel to Birmingham. And PSC support, as well as the Birmingham Liver GIPPIE group, patient public involvement group, are instrumental at helping deliver these trials. The first trial I want to talk about in red is actually using something that we have in the NHS already. Oral vancomycin is an antibiotic that we use to treat certain types of infection. And these particular types of sort of infection are like hospital-acquired diarrhea, like Clostridium difficile diarrhea. We also use it to treat other types of gram-positive organisms like Streptococcus, Staphylococcus, which many of you may have heard of. Vancomycin has particular affinity, i.e. it particularly targets Enterococcus, which I've illustrated in the previous slide, can travel from the bowel to the liver and other joint areas and cause autoimmune disease. So it's quite attractive to see whether oral vancomycin was able to lead to improvement in colitis, not just colitis activity, but also liver disease activity. So the first trial I'm going to talk about in a moment is going to explain what the early phase vancomycin trial that we did, and then I'll talk. And we are also planning a larger study to prove that those early results are valid. The second trial actually looks to replace the gut microbiota using fecal microbiota transplantation in sort of people with this autoimmune liver disease. And we're using healthy donors from people without a personal or family history of autoimmunity to try and improve the overall gut microbiome. And the third one, which is just open, seeks to bind not the bacteria itself, but the toxins that they produced to reduce the chances that they're causing disease. So I'm going to talk very briefly about these therapeutic endeavors. Next slide, please. Okay, so here you can see 3 panels, and this is a summary of results of a clinical trial that we did, repurposing a day-to-day used antibiotic for the treatment of this autoimmune liver disease. you can see this thing called fecal calprotectin on the left-hand side. That is a marker in the stool, in poo. That is a marker of gut inflammation in people with this autoimmune liver disease. What we can see in red is where the fecal calprotectin value started, and you really want these levels below 150, certainly below 100, and below 100 is ideal. And with just 4 weeks of treatment, in the absence of any active infection that we picked up, fecal calprotectin levels normalize, they improve in this particular patient group. And this improvement is dramatic, and perhaps more so than we see with many other treatments that we've got to treat gut inflammation. When we stop it, though, the vancomycin, you can see in yellow-orange that the values start to go up again. So taking away this antibiotic causes the inflammation to go up inside the bowel. And in the middle panel, you can see results of paired lower gastrointestinal endoscopies or colonoscopies, sigmoidoscopies. You can see at baseline versus on treatment, you can see the improvement that happens. Now, why do we see a relapse after we stop the agent? Well, that is because likely the factors that are contributing to that gut microbiome are still there. The diets haven't changed. We haven't been able to identify what the dietary triggers are that contribute to these things in the bowel, as well as all the other environmental exposures. We didn't change anything else. And on the right-hand side, you can see a liver blood test, which is associated with long-term prognosis, alkaline phosphatase. Again, this falls on treatment, but then relapses thereafter. Next slide, please. So the next trial, which is actively running, we don't have any results for this yet, is what we call the Fargo trial. So this is using fecal transplantation, as I mentioned. If you just click the next slide, please, Laura, then you'll see some of the text with it. We are again looking to see whether it mainly affects the liver biochemical marker, but lots of other things that are important to help understand how the interactions with gut microbiota will work. How many treatments do you need to get a more sustained change in the gut microbiota? What does it do to certain immune cell populations, leukocytes, which I mentioned here? How does it affect what the gut microbiota do, not just in how they look in terms of the composition, but how they work together? So this will be a very critical trial. We're about 60% recruited, and hopefully that recruitment will continue. The problem with fecal microbiota transplantation, though, is its scalability. I mentioned that our donors that we use are very rigorously screened, not just in terms of their personal and family history of autoimmunity, but also in terms of their dietary behavior, their smoking status, their personal circumstances, how stressed they are, all of these things. And even when somebody goes on holiday or we're entering the Christmas period, their diets change and they may fail screening. So it is certainly a very challenging trial to do, but will give us very important results. Next slide, please. And just to finish off, I just want to talk about this concept about not necessarily targeting the gut microbiota, but what they produce. So you can see sort of a timeline here. You've got non-disease liver and bowel here, sort of on the far left. And you want your microbiome to be very diverse, very rich in what we call symbionts, bacteria and other bugs that live with us in harmony. They integrate very well. But what we see in early stage primary sclerosing cholangitis, the colon becomes red, the liver starts to become affected, and that shift changes, it becomes less diverse. The barrier of the gut weakens, and you get lots of things called endotoxins that cause not just liver inflammation, but more systemic inflammation as time moves on. And what you can see on the far right is this trial that we're doing called, using these tiny carbon beads. And if you press the next slide, you can sort of see what they look like. They literally are tiny little sesame seed type shape, things. They don't get absorbed in the body whatsoever. They bind to the toxins and then you pass them out in stool. And what we've got some proof of concept data showing that it improves gut health. It makes the gut barrier stronger. And it may reduce the chances of people, even with very advanced autoimmune diseases, autoimmune liver diseases and other likes, from progressing to the point where they need major things like surgery or transplantation. And we are trying to prove sort of whether this works in a clinical trial in Birmingham in people with this autoimmune liver disease, PSC, for which there's no other medical treatment that's been shown to be effective. Next slide, please. So, I mean, that's just an overview of autoimmune diseases, some of the proof of concept data showing the gut as a contributor to it, and some of the things that we're doing in the Birmingham BRC to target these therapeutically. And thank you for your time, and I'm happy to take any questions in the Q&A.
Thank you so much, Palak, for that really informative talk. I feel like I've learnt lots, and the graphs were quite difficult for me to understand. So thanks very much for your explanations. Sorry about the delays with the, I guess there's a bit of a satellite delay or something with our moving the slides on. But we've had some great questions, which would be lovely to be able to fire at you. But I just wanted to remind people that we can't answer any medical questions, I'm afraid. That's not the purpose of today, and it's obviously not appropriate. That's really something that we recommend that you seek medical advice about you on. So I'm going to just ask you some of these questions to start with, if that's okay, Palak?
Yeah.
Okay, so our first question is, are fecal transplants successful, and if so, recommended for autoimmune patients?
So we are studying it. So certainly if the trial results are positive, and we manufacture these in-house, we have our donors in-house, we will be looking certainly for for the opportunity to roll that out and commercialize on that prospect. Now, I'm not somebody who's interested in that personally as commercialization. I want to help people with these conditions. So absolutely, I'll be a very strong proponent of making this as widely available as possible. At the moment, it is under study. So we have data from animal models. We have proof of concept data in small groups of people that, yes, it can improve symptoms and it can improve the quality of life of people and improve certain disease indices like certain blood tests in people. But we need clinical trials like the Fargo fecal transplant program to validate that in larger proportions before it becomes more accepted as a treatment.
Thank you. Do you think, so the next question, and a couple like this. So let me ask you the first part, and then I'll ask you one of the other ones before you start your answer. But can excessive sugar consumption cause gut imbalance? And there are a few questions about diet. So are there any dietary recommendations to improve or aid gut health?
Sure. Yeah, I mean, so yes is the answer. Sugar and artificial sweeteners, sadly, can affect the gut microbiome negatively. And they do cause more, what's the right word? Your body to be in a more inflammatory state. So that is the case. So artificial sweeteners and sugars can both do that. And so what was the second question? You said certain dietary recommendations.
Do you think a Mediterranean diet, for instance,
Sure.
can affect the microbiota?
Yeah, so it's a very, very good question, and one that we get asked quite often. There is no hard data to support that in terms of comparing gut microbiome, but there's lots of indirect evidence. And one or two examples of that I'll state is autoimmune diseases, and even like say, well, let's take autoimmune liver diseases for an example, are much rarer along the Mediterranean belt. We just don't see them as common. And even if you go to countries where urbanization is still ongoing, we saw, like in India, for example, we saw very few autoimmune diseases until they started adapting Western ways of food processing or ultra processing. So, trying to keep things as fresh as possible, whenever you go to the supermarket or wherever you buy your things, avoid things which have got more than 3 or 4 ingredients on them. If no one has time to bake their own bread, but that is the best type of bread you can have. But then instead go to a baker, get things without seed oils, minimal ingredients. This is a Mediterranean way of living. And that's why when you go to places like, say, Italy and other, they'll eat a lot more bread and things that we can, but their things are have very little processing. So I would say there's definitely indirect evidence. There is also some indirect evidence. And when I say indirect, it's comparing populations of people and their diet and how common things are. There is certainly evidence that drinking 3 to 4 cups of coffee a day is good for autoimmune disease, is good for your liver compared to other sort of beverages like tea and non-coffee drinkers. They don't have caffeine in it, but these type of things, are very much a Mediterranean way of living that can help improve gut health. And the last thing I'll just mention on that topic is apples. People spend hundreds, thousands of pounds in the States to try and enrich this thing called pectins in your diet. Pectins are something that strengthen your gut bacteria. But if you eat an apple a day, literally, you have so many sort of pectins in that. It strengthens your gut barrier, lowers your blood pressure. It's a really good source. So certainly, if you can tolerate it, it's definitely a good thing to do.
Wow, I've learned. Thank you. Um, do you know if there's a reason women are more prone to autoimmune diseases or conditions if environment plays such a big role?
Yeah, it's a fantastic question. I mean, there is data. I mean, maybe we could come back and do something else about sex differences and autoimmunity and why. Um, we see differences in women depending on whether they've born children, the age at which their periods first started, the timing in which they've reached menopause. All of these things have an impact in certain autoimmune diseases. One of the things that we've identified in one of the earlier autoimmune liver diseases, as an example, primary biliary cholangitis that I mentioned, is cosmetic products. We find that things such as hair dye, nail varnish, they contain these things called xenobiotics, which have certain sequences of proteins that look like certain what we call autoantigens inside the body. So you have those, your body's exposed to them. They look slightly similar to certain proteins that you see on your mitochondria, but with a slight difference. Your body recognizes that they're different and they start to attack them. But then they say, oh, look, there's something that looks very similar elsewhere in the body. Let's go for that as well. So exposure to things like hair dyes, sort of cosmetic products is also something. And in fact, as cosmetic products have been more popularized by men in certain countries, we are starting to see those same autoimmune diseases that normally we only saw 5% of men develop, now up to 25% of men developing them, and it may be related to that as an external factor.
Gosh, thank you very much. We've got loads of questions, so I'm just going to just whiz through these, and then
Sure.
we've only got time for a couple more, I'm afraid, I think. But can the gut imbalance happen because of a stoma? So as to explain a bit more about to explain a bit more about the gut microbial move elsewhere. Sorry, I'm not quite sure I've read that out properly, but can the gut imbalance happen because of a stoma?
Can the gut imbalance? I mean, yes, your gut microbiome does change if you've got a stoma. I mean, there are several different types of stoma. There are some that are temporary, where very little or no gut has been removed. It's just created as a diversion. And there are some where you remove large chunks of bowel, like the whole colon, for example, and everything in between. So it really depends on what type. But yes, anything that you take, any disruption to your gut circuit will change your gut microbiome. I'm not going to say it's so much of a disturbance, because we actually find that some autoimmune conditions, like autoimmune liver disease, they get better or they don't progress, should I say, if you have a stoma that's removed the whole of the large bowel, for example. But if you put the bowel back together again in the remaining segments, they still behave as if that operation had never happened. So interrupting the gut microbiome, taking that colonic microbiome away, seems to benefit their liver condition, for example. So yes, there will definitely be changes with every type of stoma. The different types will have different impacts, and some may be beneficial.
Brilliant, thank you. Okay, next, what percentage of people with autoimmune problems go on to develop liver issues and disease?
So I'm presuming that this is other autoimmune conditions outside of liver. It varies depending on what type of autoimmune condition we're talking about. The most common ones, like say celiac disease and thyroid dysfunction, it's a small group. It's between 2 and 5%, I would certainly say, can go on to get it. If you have inflammatory bowel disease, it's sort of similarly, it's between 5 and 15% of people can at some point develop some sort of liver abnormality. But other autoimmune liver conditions like alopecia, for example, it's uncommon to get it. Celiac disease sort of is about, I'll say about 2 to 5%, 2 to 6% can get liver problems. So many autoimmune diseases can occur together, but some have more of a chance of developing liver issues than others.
Okay, thank you very much. Um, Next question, is calprotectin related to inflammatory bowel syndrome with a microbiome dysfunction? Now, they've said inflammatory bowel syndrome. I assume they've used that because it's not inflammatory bowel disease.
Yeah, so inflammatory bowel disease is different to irritable bowel syndrome. So irritable bowel syndrome is where there is not a structural or inflammatory or visibly inflammatory component to that individual symptoms, but the bowel may move differently, but it may be more sensitive to certain degrees of stretch. It's more sensitive to external factors, including sleep, diet, etc. There is no, at least to my knowledge, and there's no good evidence that the gut microbiome in irritable bowel syndrome consistently plays a role. I'm sure it does in a subgroup of individuals, but not in everybody to the same degree that we see in inflammatory bowel disease, where the bowel is actually actively inflamed. And fecal calprotectin itself, I mean, as a biomarker in stool, it's very good. But if we see very high fecal calprotectin values, we are very much thinking of inflammatory bowel disease, not irritable bowel syndrome, which where we don't tend to see that.
Okay, thank you. With IBD as the primary inflammatory disease, would the liver disease come as a secondary issue later on in life?
It can do, yes, it can do. So most people with autoimmune liver diseases, for instance, who've got inflammatory bowel disease, the inflammatory bowel diseases come first, and it can occur at any point. So we have most people have inflammatory bowel disease for about 5 to 6 years before we start to develop some form of autoimmune liver disease. Some can have it for much longer, and some never get it. It's as I said, it's 5% of people is what we tend to quote. Some studies have shown that up to, in some populations, if you follow people up long enough, like 20 years or so, the values can go up higher to sort of 14, 15% of people developing some form of autoimmune liver condition. But inflammatory bowel disease care on the whole would involve regular blood testing, so every 6 to 12 months. So that should hopefully identify any problems before they, or any abnormalities, should I say, before there's a big problem with your liver.
Okay, thank you. And I'm afraid, final question. I know there's lots more questions there, but does excessive stress affect the microbiome negatively?
Yes,
Do you think?
absolutely. Yeah, absolutely. So if you think about when you're stressed and your body produces various hormones, people can sometimes get palpitations, they can they can become angry, they can become upset. All of these things, all these emotions are triggered by hormones that your body release. And a sustained and consistent pattern of this increased stress hormones will negatively affect your gut microbiome. And we are now learning that shift workers, doctors, nurses, for example, people who exclusively work night shifts in security, aircraft pilots, submariners. We've got one of my colleagues has got a PhD student doing a study of submariners and what happens to their microbiome. These things have very negative consequences on the gut microbiome, and a lot of people who live in very high stress jobs or work high stress jobs, which go with very little sleep, they'll find as they grow older, so ages of 45, 50 years old, that they're often triggered to wake up in the morning because they need to go to the toilet. And that type of thing is very much driven by the lack of sleep and stressful life and the changes to the gut microbiome that have ensued as a result. So absolutely, but it is fixable. Be happy, de-stress, life is good.
Okay, well, thank you very much. I think there's a song about that, isn't there?
There is. Yeah.
Thank you so much. And I'm going to have to start to draw this to a close now. And I just wanted to say you did a fantastic name check of some of our amazing colleagues earlier as well, who are so vital to getting trials in place. Because without the research, without the trials taking place, we don't have these amazing steps forward, do we? And we don't know as much as we know, because thank you very much for all the people that go on to trials. And so what we're going to do is just say, please do think about, being on a trial. We would love you to consider that if you think that's up your street. And we're going to put in the chat now a link to that. But also, everyone that's registered, you'll get a copy of. We'll send you the links and so on as well. So again, if you thought that was something you wanted to do, you can just register or sign in, or sign up to be part of taking part in clinical trials. Because without you, it doesn't happen. And without these people and all the different events that we do to get people involved in the research even before when we're just even applying for grants, we don't have these amazing trials happening. Because actually we really need to know from people with lived experience just exactly how it is that it affects them, and it really helps to shape the research we do. So we also really want to hear from people who want to be involved in actually shaping those trials and actually making sure that we actually get it right, because it definitely makes the research that we do much better then. because sometimes there's nothing like speaking to someone who's actually had that disease themselves. So we would really like to get your feedback on today as well. And Becky's very carefully putting in the information, because we'll also send you a link to, and this is our website as well. You can join up that way and get involved. But we'd love you to give feedback on today's webinar, so we can improve for the next time. And the next one is actually going to be in January, not too long to wait now. Can you believe it? It's going to be 22nd of January, and it's going to be by our theme leads from acute care and infection. Professor Liz Sapey and Dr. Susie Gallia will be talking about saving our antibiotics, understanding resistance and how data can prevent it. So we've obviously talked a little bit about antibiotics today, and I know a lot of people have a lot of interest in that. So we very much hope that you would sign up to be part of that. And again, look out. We'll send links in the emails that we send out to you now, but please do think about joining us again. And in the meantime, all that remains for me is to say, on behalf of Palak, myself, and the rest of the team at the BRC, have a fantastic Christmas break. If you get the opportunity, you can watch back on this when it's actually recorded and uploaded onto our website, but you'll also get a copy of it. And we really appreciate your commitment and interest to the research. So have a good evening, and thank you very much for joining today. Bye-bye.